Welcome to the deep dive. Today we're getting into something pretty fascinating based on the sources you sent over, intimal hyperplasia.
Right.
Now, it sounds technical, but it's basically how our blood vessels react when they get injured.
Exactly.
And, like a lot of things the body does, this reaction can be helpful, but sometimes it causes problems.
It's a real double-edged sword, isn't it?
It really is. So our mission today is to unpack what this intimal hyperplasia thing is, why it pops up in those different scenarios you were looking at, and really highlight the key takeaways without, drowning into the super technical stuff.
Sounds like a plan. Think of it as the body's repair crew for blood vessels. It's a healing response.
Okay.
But what's also really interesting is that this same process is vital during development. It actually helps shape our circulatory system when we're growing.
Wow. Okay, so let's dig into the nuts and bolts then. What actually happens inside the blood vessel when this whole thing kicks off?
Well, it typically starts with some kind of damage to the inner lining, that's the endothelium.
Right, the lining.
When that gets disrupted, maybe the smooth muscle cells just underneath are affected too. It sets off a kind of chain reaction. Platelets start sticking to the damaged spot.
The blood cells.
Yeah, the tiny ones involved in clotting. And then the body's inflammatory response gets triggered.
So like the body hitting the panic button at the injury site.
That's a pretty good analogy, yeah. And this initial damage, it sends out signals to the smooth muscle cells deeper in the vessel wall.
Okay.
These cells then start moving, migrating towards that inner layer, and they begin to multiply, proliferate.
They make more of themselves.
Exactly. And at the same time, they start laying down this sort of scaffolding material. It's called the extracellular matrix.
Ah, okay.
And the end result of all this activity is a new layer of tissue forms inside the vessel. We call it a neo-intimal lesion.
Neo-intimal lesion.
Right. And depending on how thick that gets, it can start narrowing the vessel, restricting blood flow.
Which definitely sounds like something you'd want to avoid if possible. Does this happen all at once, or are there stages?
Oh, it definitely unfolds in stages. It's not instant. It's actually quite similar to how a cut on your skin heals over time.
Okay.
There's a really early hyperacute phase, minutes to hours after the injury, then an acute phase, which lasts hours to weeks, and finally a more chronic phase, stretching out over weeks, maybe even months.
Weeks to months, wow. And if we could actually see this lesion, what does it look like?
Your sources mention it's usually pretty firm, looks pale, and sort of homogeneous, all the same texture.
Okay.
In an artery, you'd find it in that subintimal space, just between the very inner endothelial lining and another layer called the internal elastic lamina.
So it's a definite physical change inside the wall. Does it always happen in just one spot? Is it always localized?
Not necessarily. It can be focal, meaning right there at the injury site, like where, say, two vessels are sewn together in surgery and anastomosis.
Right, the connection point.
Yeah. Or it could be more diffuse, spread out over a larger section of the blood vessel.
Okay, so location matters. But you said earlier, and this is really interesting, that this whole process isn't always bad news. Can you expand on that adaptive side?
Absolutely. It's crucial, actually. We often focus on the problems it causes after injury, but intimal hyperplasia is essential for normal development.
Like how?
Well, take newborns. It's the key process that closes off two specific blood vessels, the ductus arteriosus and the ductus venosus, which are needed in the womb but have to shut down after birth for the baby's circulation to work properly.
Huh, I never knew that.
Yeah, and it also plays a role in how our arteries mature and adapt as we age. Even when surgeons use a vein, say from the leg, for a bypass in the arterial system, that vein undergoes changes, including intimal changes to adapt. It's called arterialization.
That's fascinating. The exact same biological process, doing good work in one context and causing trouble in another.
Precisely.
Which really brings us to the core question, doesn't it? How does this necessary adaptive response flip into becoming a harmful pathologic one?
That's the million-dollar question, really, and researchers are still working out all the details. What's wild is that the good adaptive and the bad pathologic intimal hyperplasia share a lot of the same basic machinery.
Like what?
Things like blood clotting mechanisms, inflammation, cells growing and moving, changes in that structural matrix, and the overall remodeling of the vessel. You see those in both.
Okay.
But there are definitely unique triggers and features that push it one way or the other.
Let's explore the good side a bit more first. How does it work in those newborn developmental situations you mentioned?
So when a baby is born and starts breathing air, there are big shifts in blood flow resistance and, crucially, oxygen levels. This causes those two fetal vessels, the ductus arteriosus and venosus, to clamp down really fast due to lack of oxygen or hypoxia.
Okay, they constrict.
Right. But the permanent closure takes weeks. The low oxygen in these closing vessels actually triggers programmed cell death apoptosis in the smooth muscle cells.
The cells die off.
Purposefully, yes. And as they die, they release growth factors. These factors then stimulate the intimal hyperplasia and fibrosis, the scar tissue formation, that completely seals off those vessels. It's a really elegant, controlled demolition and sealing process.
Wow, okay. Very precise. What about as we just grow older? Does intimal hyperplasia play a role in normal aging?
It does, yeah. As we age, our arteries tend to naturally get a bit wider and the walls thicken. Even without any atherosclerosis, plaque buildup, the combined thickness of the inner intimal layer and the middle medial layer can almost triple between our 20s and our 90s.
Triple? Really?
Yeah. The media, the middle layer, stays pretty stable, but the intima gradually thickens over our lifetime. But here's the adaptive part. The artery often undergoes what's called outward remodeling, meaning the overall diameter of the artery increases even as the intima thickens. This helps maintain the lumen size, the opening for blood flow.
Ah, so it compensates.
Exactly. It's even been suggested that maybe a slower rate of this thickening could indicate slower vascular aging, while a faster rate might mean accelerated aging.
That's quite a thought, your artery lining is an aging clock.
Kind of. And things like high blood pressure or diabetes can mess with this balance, causing more matrix deposition and making the arteries stiffer, which then influences how intimal hyperplasia might develop later if there's an injury.
Okay, let's shift then to the bad side, the artery's response to injury. What kind of injuries typically trigger this problematic intimal hyperplasia?
In a clinical setting, most of the arterial injuries we're talking about actually come from medical treatments.
Oh, really? Like what?
Things like angioplasty, using a balloon to stretch open a narrowed artery, or bypass surgery. Angioplasty in particular creates a very controlled, localized injury.
And because it's common, it's studied a lot.
Exactly. It's a very common model for researching intimal hyperplasia in the lab.
So what's the immediate reaction right after an injury like that?
The very first thing is hemostasis stopping any bleeding. Damage to that inner endothelial lining exposes the stuff underneath, the subendothelial matrix.
Okay.
This immediately makes platelets rush in and stick together, forming a sort of temporary plug. This platelet activity usually peaks around 8 to 10 hours after the injury.
And that's why antiplatelet drugs like aspirin are given.
Precisely. They're targeting this very early platelet aggregation phase. There are specific receptors on platelets involved, like GPI and others, plus factors like a von Willebrand factor. Some drugs specifically block the GPIBA receptor to reduce clotting after procedures like PCI.
Okay, so platelets arrive first. What else happens early on?
The whole coagulation cascade, the blood clotting system involving tissue factor and various clotting factors like VAA, ZAA, and thrombin also gets activated. This contributes to kicking off the intimal hyperplasia process. Controlling this early clotting is also key to preventing acute stent thrombosis, a dangerous complication.
Right.
And interestingly, there's also cell death, apoptosis happening. Within an hour or two, some cells in the intima media die off. This drops off, but then, weirdly, it increases again around day 7, maybe up to half the cells in the media. Then it decreases again by day 14.
Huh. Why would it increase again later?
It's thought it might be linked somehow to the proliferation, the cell growth that's also ramping up around that time. It's a very dynamic, early phase damage, clotting, cell death, and the beginnings of repair all happening.
It sounds incredibly busy right after the injury. Where does inflammation fit in?
Inflammation follows hot on the heels of those early events. Immune cells, particularly neutrophils and then monocytes, are recruited to the site.
What attracts them?
Signals from the platelets already there, from the damaged endothelial cells, the exposed matrix, even the injured smooth muscle cells themselves are calling them in.
Okay.
And there's a whole sequence of adhesion molecules that pop up on the surface of the endothelial cells and smooth muscle cells after something like angioplasty, things like VSAM and IChem. These act like Velcro, helping the immune cells stick.
And these molecules stick around for a while.
They're usually upregulated, but tend to return to baseline levels by about day 30.
What do these inflammatory cells actually do once they arrive?
They release a whole host of signaling molecules, including chemokines.
Chemical messengers.
Exactly. Think of them as directing traffic. They're involved in almost every stage of the vessel remodeling. They signal more monocytes to come in, which fuels more inflammation, but they also directly stimulate the smooth muscle cells to start multiplying.
Are there specific ones that are important?
Yes, certain pathways are key. The MCP1-CCR2 axis is a big one for monocyte infiltration and growth of the neo-intima. Rontes, acting on CCR1 and CCR5, also regulates monocyte recruitment and neo-intimal growth. Another one, CXCL1, seems to help with rehealing the endothelium and intimal growth by bringing in progenitor cells. It's a complex communication network.
A network of signals driving the process. And cytokines are involved too, right? I remember reading that.
Absolutely. Cytokines, that's a broad category, including things like TNF, interleukins, TGFs, are pumped out by both the inflammatory cells and the injured vessel cells.
And what's their role?
They kind of amplify everything. They propagate inflammation, make cells stickier, promote proliferation, migration, even cell death. They can increase oxidative stress, activate various pathways inside cells, and interact with other molecules like integrins and MMPs to remodel that extracellular matrix.
It sounds like controlling inflammation could be a key strategy.
Definitely. There's research looking at modulating the type of macrophages present, for instance, which might reduce intimal hyperplasia. Some studies even looked at low-dose inhaled carbon monoxide before angioplasty, which seemed to attenuate the response by altering leukocyte function.
Carbon monoxide, really?
Yeah, kind of surprising, right? And blocking other specific cytokines, like IL-1, showed a trend towards reducing restenosis after interventions in leg arteries. Also, giving a growth factor, GCSF, boosted endothelial repair cells and reduced neo-intima size in some studies.
So lots of potential targets there. Let's get back to the smooth muscle cells. They start multiplying after injury.
They do. Normally, in a healthy artery's middle layer, less than 1% of smooth muscle cells are dividing at any time. They're quiescent.
Very quiet.
Right. But within 48 hours of an injury, that can shoot up to over 20% actively proliferating.
Wow, that's a huge jump. What triggers that?
The initial burst is likely driven by a growth factor called BFGF, basic fibroblast growth factor, which gets released from damaged cells right away.
And then they move.
Yes, they need to migrate from that middle layer, the media, into the inner subintimal space. To do that, they need enzymes called MMPs, matrix metalloproteinases, to basically chew through the matrix, holding them in place.
Okay, break down the wall a bit.
Sort of. And then their movement is guided by various signals like PDGF, BFGF, VEGF, chemokines, thrombin. Lots of things tell them where to go.
Has blocking those signals worked?
People have tried. Blocking one specific pathway, the PDGFR pathway, looked really good in animal models. It really shut down intimal hyperplasia, but unfortunately it didn't pan out in human trials.
That's often the case, isn't it?
It is. It also turns out that some of the cells contributing to that buildup in the inner layer might actually come from circulating stem cells, mesenchymal stem cells, that arrive and then differentiate into smooth muscle-like cells.
So not all from the original vessel wall.
Potentially not, no.
Once these smooth muscle cells get into that inner layer, what happens?
Well, that's where the proliferation really peaks, usually around day 14 after the injury. It then gradually settles down back towards backline by about day 28, assuming the endothelial lining heals properly.
And if the lining doesn't heal quickly?
Then the proliferation can drag on for much longer, maybe up to 12 weeks. But even after the cell numbers stabilize, the neo-intima, that new layer, keeps growing because the cells continue to produce and lay down more extracellular matrix, especially collagen and proteoglycans.
So the layer gets thicker even if the cells aren't dividing as much.
Exactly. And an increase in collagen can actually make the smooth muscle cells become more contractile, which paradoxically can lead to the artery shrinking inward over time. That's the negative remodeling we mentioned.
Negative remodeling. Okay. Now, what about myofibroblasts? The sources mentioned them too.
Right. Myofibroblasts, they're definitely important. They're kind of a hybrid cell, characteristics of both smooth muscle cells and fibroblasts. And they show up pretty early, by day 2, and can make up a really significant chunk, maybe even half, of the cells in the neo-intima by day 14. Some might come from those circulating stem cells, too.
And what do they do?
They're famous for their role in wound contraction elsewhere in the body. It's thought they might do something similar in the vessel wall, contributing to that chronic shrinking or negative remodeling.
Ah.
And it's interesting, when researchers looked at tissue removed from arteries that had re-narrowed after treatment, they often found low levels of cell proliferation, but high levels of cell migration and collagen production.
So it's not just about cell numbers, but what the cells are doing, how they're changing the structure.
Exactly. The remodeling of that intimal tissue itself plays a huge role in the final lumen size.
We spent a lot of time on the inner layers. What about the very outside layer, the adventitia? Is it just sort of there for support?
That's what people used to think, mostly. Just structural support, carrying some nerves and tiny blood vessels.
But that's changed.
Big time. We now recognize the adventitia as a really active player. It's a source of regulatory cells that can influence everything happening deeper inside the vessel wall. It's sometimes called the outside-in hypothesis.
Outside in. Interesting. What's in the adventitia?
It's got fibroblasts, some smooth muscle cells, fat cells, resident immune cells, and importantly, stem and progenitor cells.
Cells.
Yeah, cells that can actually migrate inwards and become part of the media or the neo-intima during healing or disease. Plus, it has the vasorum, the vessels of the vessels that feed the artery wall itself, lymphatics, nerves, all embedded in its own matrix. The collagen there also helps prevent the artery from overstretching.
So, way more than just a wrapper. How does it contribute to intimal hyperplasia after injury?
Well, studies show that very early after injury, myofibroblasts in the adventitia start churning out signaling molecules like MCP1.
Chemokine we talked about.
Right. And that recruits monocytes, those immune cells, into the adventitia itself. Adventitial fibroblasts can also get activated by other pathways, like sonic hedgehog signaling or increased oxidative stress, and this activation contributes to neo-intima formation further inside.
So it's coordinating the response from the outside.
It seems to be a major coordinator, yes. And those adventitial myofibroblasts also play a role in that negative remodeling, the shrinking. Plus, as we age, the number of resident inflammatory cells in the adventitia seems to increase naturally.
Which might explain why older vessels are more susceptible.
That's one theory, yeah. It could contribute to increased susceptibility to atherosclerosis and intimal hyperplasia, so the adventitia is definitely not just passive.
That outside-in idea really changes the picture.
Yeah.
Okay, let's connect this back to clinical factors. Does how bad the initial injury is make a difference?
Oh, absolutely. There's a pretty direct relationship. If the injury is superficial and doesn't damage the middle layer, the media, you see very little intimal hyperplasia. But the deeper the injury goes into the media, the greater the proliferative response. It really suggests that injuring those medial smooth muscle cells is a key trigger.
Makes sense.
And interestingly, even just stretching the smooth muscle cells without actually scraping off the endothelium can stimulate them to proliferate.
Just the stretch itself.
Seems so. The length of the injured segment also matters because that correlates with how much endothelium is lost.
And why is losing endothelium so bad?
Because until it grows back, which happens from the edges of the injury and maybe from those little vasa vasorum in the adventitia, the underlying smooth muscle cells are missing the normal calming signals from the endothelium, like nitric oxide and prostacyclin.
So they're unregulated.
In a way, yes. And in really severe injuries, the vessel lumen can get compromised by both the sheer bulk of the neo-intima and that negative remodeling process we discussed. Deep medial damage really kicks off adventitial myofibroblast proliferation, driving that shrinkage.
So, worse injury, bigger response, potentially worse outcome. What about blood flow itself? Does the way blood flows through the vessel matter?
Hugely important. Hemodynamics affect both healthy and diseased vessels.
How so?
Well, clinically, if someone has angioplasty in their leg and the blood flow out of that area is poor, they tend to have higher rates of restenosis, reduced runoff, as they call it.
Okay.
And experimentally, blood flow and the friction it creates on the wall, shear stress, are strongly linked to intimal hyperplasia development. Low shear stress tends to promote it.
And high shear stress.
High or normal shear stress is generally protective. Increased flow has been shown to reduce intimal thickness, while decreased flow increases it.
So flow directly affects the cells.
It seems to have a direct impact on smooth muscle cell function, yes. Although once you have a well-established lesion, just changing the flow might not be enough to make it regress significantly.
Yeah.
The structural changes are already there.
Right, the damage is done, so to speak. What if the vessel was already diseased before the injury, like with atherosclerosis?
That generally leads to an exaggerated response. Animal models with high cholesterol, for example, show much more inflammation and intimal hyperplasia after an injury, and the lesions often look more like atherosclerotic plaques.
Found in people.
We see similar links. Patients with high cholesterol often have higher restenosis rates after procedures. The thinking is that hyperlipidemia might expand certain types of monocytes that are particularly aggressive in targeting injury sites, leading to more oxidative stress, inflammation, and smooth muscle cell activity.
So the underlying disease primes the pump for a bigger reaction.
It seems that way. And other risk factors for atherosclerosis also boost intimal hyperplasia. Smoking, for instance, doubled experimental intimal hyperplasia in one study. Statins, the cholesterol drugs, have shown some benefit in reducing restenosis, but they likely work through multiple mechanisms, not just directly on the hyperplasia.
Okay. And diabetes. That's a huge factor in vascular disease.
A major predictor, yes. Diabetes significantly increases the risk of augmented intimal hyperplasia and restenosis after vascular injury.
Why is that?
Animal models consistently show increased inflammation and hyperplasia in diabetic conditions after injury. Even prediabetes or metabolic syndrome can upregulate those adhesion molecules we talked about, leading to more macrophage infiltration and neo-intima formation. There's also increased expression of receptors for oxidized LDL.
And AGs.
Yeah.
Advanced glycation end products.
Yes, AGs are a big player. They accumulate with age anyway, but much more so in diabetes. They're found all over atherosclerotic lesions.
And they cause problems.
They interact with specific receptors called RAGE on inflammatory cells and smooth muscle cells. This interaction stimulates inflammation, smooth muscle cell proliferation and migration, and matrix production, basically hitting all the key steps of intimal hyperplasia.
And RAGE itself is affected by diabetes.
Yeah. Yes, RAGE expression goes up in diabetes and also after vessel injury. And RAGE doesn't just bind AGs, it binds other danger signals released from injured cells too. So it's a key receptor in this whole process.
Has blocking RAGE helped?
Inhibiting RAGE has shown promise in reducing neo-intima formation in both diabetic and non-diabetic animal models.
And clinically, in diabetic patients?
Clinically, diabetic patients definitely have higher rates of restenosis, and they're more likely to have it happen again even after retreatment. Interestingly, when you look at the tissue from restenotic lesions in diabetics, it sometimes has fewer cells but more collagen-rich matrix.
Suggesting what?
Suggesting that negative remodeling or recoil might be playing a bigger role in their restenosis compared to non-diabetics. Diabetes just seems to create this pro-hyperplasia environment in the vessels.
Definitely sounds like a tougher situation.
Right.
Okay, let's pivot to some specific clinical scenarios. How does intimal hyperplasia play out after different treatments? Let's start with basic balloon angioplasty.
Right. After just balloon angioplasty, if the artery narrows down again, that's restenosis, it's usually due to a combination of factors.
Pretty far.
Platelet aggregation, the intimal hyperplasia itself, the natural elastic recoil of the artery wanting to spring back, and that negative remodeling or shrinking of the vessel over time.
Okay, a mix of things. How does putting in a stent change that picture?
Stents are basically scaffolds. They physically prop the artery open, so they're very good at minimizing that immediate elastic recoil and the later negative remodeling.
So they solve those problems.
They address those specific mechanical problems, yes, but the stent itself is a foreign body and causes injury. So with instant restenosis, the main culprits become platelet aggregation right after placement, the ongoing endothelial injury caused by the stent struts, and then the intimal hyperplasia growing through the stent mesh.
So the biology is a bit different compared to just angioplasty.
It is. The stent introduces its own set of inflammatory responses. Stents are often used when balloon angioplasty alone doesn't work well, or if the artery closes right back down, or tears, or has already restenosed before.
Right.
And imaging shows that stents don't always push perfectly flat against the vessel wall. You get uneven injury with more intense injury right where the metal struts dig in.
Which could drive more hyperplasia locally.
Exactly.
So what happens biologically right after a stent goes in?
Well, it gets coated with blood proteins like fibrinogen almost instantly, within a minute. The gaps between the struts can fill with thrombus or clot. Platelet and leukocyte adhesion is actually enhanced, maybe due to electrostatic effect.
And the smooth muscle cells.
Their proliferation and migration happens similarly to balloon injury, but it's often more robust and lasts longer, largely because the stent itself provokes a sustained inflammatory response. It's often worse right at the ends of the stent.
And the adventitia reacts too.
Yes, the adventitial response is also more prolonged, sometimes with giant cell formation, part of a foreign body reaction. While the stent prevents recoil, it can actually cause the medial layer underneath it to thin out over time, atrophy.
What about inflammation around the stent struts?
In the first couple of weeks, you always see fibrin, platelets, acute inflammatory cells right around the struts. The severity depends a bit on what the stent is pushed against. It's worse if it's adjacent to injured media or a lipid-rich plaque core, and chronic inflammation can linger.
Does the plaque get squished?
Often, yes. Plaque gets compressed, and it's quite common for struts to actually penetrate into a fatty lipid core.
And the neo-intima, when does that appear?
It starts developing within about 2 weeks. Ultimately, whether a stent is successful long-term often comes down to how much neo-intima grows inside it, not necessarily the initial size achieved.
Is the growth worse if the vessel wall was already damaged?
It does tend to be thicker if there was significant medial damage, and using a stent that's relatively too large for the artery also seems to correlate with more instant neo-intima.
But the tissue itself is similar.
Yeah, despite these differences, the actual cell density and the type of matrix laid down in the neo-intima seem pretty similar to what you see after balloon angioplasty alone.
Okay, so stents help mechanically, but trigger their own biological response.
Yeah.
This brings us to drug-coated balloons, or DCBs. What's the idea there?
The idea with DCBs is to deliver an anti-proliferative drug, usually paclitaxel, directly to the vessel wall during the balloon inflation. The pressure helps push the drug into the tissue.
And the goal?
The goal is to reduce that local intimal hyperplasia and subsequent restenosis, hopefully improving patency, without leaving a permanent stent implant behind, which avoids the chronic inflammation and potential issues associated with stents.
How does paclitaxel work?
It stabilizes microtubules inside cells. These are part of the cell's internal skeleton and are crucial for cell division, mitosis. So paclitaxel essentially stops cells from dividing.
Which cells?
Pretty much all proliferating cells it comes into contact with. It's not specific.
So what's the effect on the vessel wall?
You get reduced intimal hypoplasia, which is good, but you also see delayed healing overall.
Delayed healing. How?
You might see increased fibrin deposition, slower regrowth of the endothelial lining, and even some loss of smooth muscle cells in the media. This delay in endothelial healing might explain why vessels treated with DCBs sometimes take longer to regain normal function, like endothelium-dependent vasodilation.
What have the clinical results been like for DCBs?
In the legs, particularly the femoropopliteal arteries above the knee, they've shown pretty good results, improved patency, and reduced need for repeat procedures out to 5 years in some studies.
But not everywhere.
Not as consistently successful in the arteries below the knee, the infrapopliteal arteries. And there's been significant controversy recently about a potential link between paclitaxel-coated devices, both DCBs and stents, and increased long-term mortality.
Mortality, that's serious.
Very. The cause isn't fully understood, but some wonder if it relates to the higher drug doses sometimes used in peripheral devices compared to coronary ones, or maybe systemic effects of the drug particles. It's under intense investigation.
Are other drugs being looked at for DCBs?
Yes, rapamycin and its analogs like sirolimus are being explored. Sirolimus inhibits cell proliferation through a different pathway, the MTOR pathway. Sirolimus-eluting stents have generally shown better patency and safety compared to paclitaxel-eluting stents in many settings.
Okay, so the drug choice matters. Let's talk more about drug-eluting stents, DUESS. How do they compare to DCBs?
So DES are stents coated with a drug, again, usually sirolimus or paclitaxel or their relatives, that's released slowly over time from the stent itself, often using a polymer coating.
Same goal, stop the cells from growing.
Primarily targeting the smooth muscle cell proliferation to reduce in-stent restenosis, yes. They've been a mainstay in coronary arteries since the early 2000s and used peripherally since about 2012.
Sirolimus versus paclitaxel again.
Early coronary DES used both. But newer generations, especially in the heart, tend to favor the sirolimus family drugs like everolimus or zoterolimus. They seem to have better pharmacokinetic properties and maybe wider therapeutic windows.
Do they have downsides?
Yes. While they inhibit smooth muscle cells, they also inhibit the endothelial cells needed for healing the lining. They can slow endothelial migration and proliferation, and even hinder the body's own endothelial progenitor cells from homing in and helping repair the damage. This delayed reendothelialization is a concern.
Does it cause other problems?
Both sirolimus and paclitaxel can potentially cause some endothelial dysfunction downstream from the stent, and might even make endothelial cells produce more tissue factor, which could contribute to thrombosis risk.
And the polymer coating.
That's another factor. The polymers used to control drug release can sometimes cause hypersensitivity or inflammatory reactions themselves, which have been linked to late stent thrombosis in some cases. Newer DES often use more advanced polymers or even polymer-free designs and more lipophilic sirolimus derivatives that penetrate tissue better, aiming to reduce these risks.
So coronary versus peripheral DES.
Coronary DES now predominantly use sirolimus or its analogs. Peripheral DES have more commonly used paclitaxel, partly because peripheral sirolimus-eluting options have been slower to market, though they are coming.
And outcomes.
Cardiology literature generally suggests superior outcomes, including better safety with lower thrombosis rates for the newer coronary sirolimus analog stents compared to older DES, including paclitaxel ones. And as we mentioned, peripheral paclitaxel DES are under scrutiny due to those mortality concerns.
It really is a constantly evolving field, trying to balance efficacy and safety. Okay, let's switch gears completely. What about using a patient's own vein as a bypass graft? How does intimal hyperplasia factor in there?
Using the patient's own saphenous vein is often the gold standard for bypasses below the groin, but these veins aren't always pristine.
What kind of issues?
They can have thickened walls, maybe scarring from previous phlebitis, varicosities. Studies show a high percentage have some fibrosis even before use. And veins classified as diseased beforehand tend to have about half the patency rate compared to non-diseased ones.
Can you predict which ones will fail?
Not easily, unfortunately, unless there's obvious gross disease. The underlying causes of vein pathology are complex.
So what happens when you put a vein into the high-pressure arterial system?
It has to adapt. This process is called arterialization. The vein wall thickens, develops more smooth muscle layers, hopefully while keeping the endothelium intact.
Is there inflammation?
Yes, early on you see expression of adhesion molecules like E-selectin and VSAM1 on the endothelium, and recruitment of neutrophils and monocytes.
Does the vein narrow?
Interestingly, while the wall thickens, the vein often dilates overall in the first year or so, maybe due to the different shear stress patterns. This helps preserve the lumen initially.
But problems can still arise.
Yes, if the vein has pre-existing focal disease, you can get maladaptive focal intimal hyperplasia developing on top of the normal arterialization, leading to stenosis.
So what causes vein grafts to fail?
Early failure is often due to acute thrombosis, a clot. But later failure, months to years down the line, is primarily due to intimal hyperplasia causing stenosis.
Is it the same process as in injured arteries?
It's not entirely clear if it's identical. Progenitor cells might play a larger role in vein grafts. Some studies suggest a significant portion of the new endothelial cells can come from circulating progenitors, even from the bone marrow.
Does the adaptive thickening usually cause problems?
The diffuse arterialization thickening is usually self-limited and doesn't compromise the lumen because of that outward remodeling. It often becomes quiescent within a couple of years. The problem is focal areas developing persistent, progressive intimal hyperplasia.
Where do these narrowings usually occur?
Peripheral vein graft stenoses are mostly neo-intimal tissue. They're more common at sites of unrecognized defects or abnormalities in the vein conduit itself, actually less common at valve sites or where tributaries were tied off, surprisingly.
Does handling the vein during surgery matter?
Hugely. Surgical preparation inevitably causes some endothelial and smooth muscle injury, which kickstarts intimal hyperplasia. Minimizing trauma during harvest is absolutely critical.
So gentle handling is key.
Definitely. The condition of the vein before implantation impacts its later function. Poorly prepared grafts get more hyperplasia and can become overly contractile. Damaging the adventitia during harvest disrupts the vasa vasorum, causing hypoxia and inflammation.
And the adventitia is important for healing too.
Yes, it's a reservoir for stem cells that can help re-endothelialize, and the fat around the vein contains inflammatory cells that get activated by injury.
What about no-touch harvesting techniques?
The idea is to reduce injury and preserve the adventitia to limit hyperplasia. But paradoxically, techniques specifically designed to reduce adventitial injury, like in situ bypass or endoscopic harvesting, haven't consistently shown better graft performance. It's complex.
What else can go wrong during preparation?
Over-distending the vein, blowing it up with too much pressure, say, over 150 mmHg Hg increases failure risk, likely by stripping off the endothelium. Even the skin markers used can damage the lining.
Wow.
And then there's the arterial environment itself. The hemodynamics, the pressure and flow can activate signaling pathways in the smooth muscle cells, triggering proliferation. Lower flow rates are linked to greater intimal thickening in vein grafts. Increased wall tension is also implicated.
So it's the veins condition, the surgery, and the new environment all playing a role. What about the patient's overall health?
Well, most patients needing bypasses have underlying arterial disease and risk factors. High blood pressure, interestingly, doesn't seem to strongly impact vein graft hyperplasia or atherosclerosis, at least in coronary grafts.
But cholesterol does.
Yes, hyperlipidemia is definitely linked to vein graft disease and failure. both experimentally and clinically.
And diabetes.
Diabetes might not significantly impact very long-term patency, but it seems to enhance short-term intimal hyperplasia in animal models due to exaggerated inflammation, and having both diabetes and hyperlipidemia seems to have an additive detrimental effect in experiments.
What do these lesions look like early on?
Human coronary vein graft biopsies after about a month show mostly proliferating smooth muscle cells with relatively few macrophages.
Are there clear patient factors linked to vein graft disease?
Studies haven't found strong, consistent associations with patient age, sex, symptoms, hypertension, diabetes, or even the condition of the outflow vessel. Stenosis might be slightly more common further down the leg.
What about blood markers?
Some factors seem potent risks for vein graft stenosis, like elevated plasma fibrinogen or homocysteine. Antibodies to cardiolipin have also been associated with failure in leg bypasses. Other factors like platelet dysfunction, lipoprotein, smoking, serotonin levels have been suggested, but findings are mixed.
Does lowering cholesterol help vein grafts?
Yes. Lower serum cholesterol correlates with reduced vein graft disease long term. Aggressive lipid-lowering therapy clearly improves patency, especially in patients with familial hypercholesterolemia. Large studies post-CABG showed vein graft atherosclerosis worsens with age, but lipid-lowering significantly reduces it, regardless of when treatment starts. Gemfibrozil also helped delay progression in men with low HDL.
So managing lipids is crucial. You mentioned accelerated atherosclerosis in vein grafts.
Yes, vein grafts that develop occlusive disease can show histologic signs of atherosclerosis surprisingly early, even within 6 months. It's often called accelerated atherosclerosis.
How is it different from regular atherosclerosis?
Morphologically, it tends to be more diffuse and concentric, more cellular, with variable amounts of lipid and immune cell infiltration. It shares features with intimal hyperplasia, but is likely more macrophage-driven. The endothelium over these lesions often expresses MHC class II antigens, which you don't typically see in spontaneous atherosclerosis.
Have attempts to directly target intimal hyperplasia in vein grafts worked?
Limited success so far. Big trials like PREVENT-3, using an E2F decoy oligonucleotide designed to block cell cycle progression, failed to improve vein graft performance.
Any promising research?
Animal studies suggest potential benefits from things like preservation media containing carbon monoxide, or even perioperative protein restriction, which boosted endogenous hydrogen sulfide and reduced inflammation and hyperplasia in rodents.
What about mechanical approaches?
Externally stenting saphenous vein grafts during CABG has shown decreased intimal hyperplasia in clinical studies. The idea is it might promote a more consistent lumen diameter and reduce abnormal shear stress, so maybe a combination of mechanical and pharmacological strategies will be needed.
Fascinating. Okay, let's move to prosthetic grafts, the artificial ones. How does the body react to those?
Prosthetic grafts, usually polyester like Dacron or PTFE like Gore-Tex, have been around since the 50s. They work well for large arteries, like aortic aneurysm repair.
But not small ones.
They perform poorly in smaller arteries, especially below the knee. The main failure modes are thrombosis and anastomotic intimal hyperplasia right at the connection points.
What happens inside these grafts after implantation?
Explants from humans show early on, first few weeks, red cells, fibrin, some macrophages at the anastomoses and on the surface. Later, months to years, you might see a single layer of endothelial-like cells and a thin fibrin layer covering the anastomotic segments, along with developing intimal hyperplasia, smooth muscle cells, collagen.
Does it keep getting thicker?
The anastomotic hyperplasia seems relatively stable after the first few years in many cases. You also find chronic inflammatory cells within the incorporated graft material. The tissue around the graft grows into and encapsulates it over time.
Does the whole inner surface heal?
This is a key difference from animals. In humans, there's generally no evidence of full transmural endothelialization, meaning the body's own lining growing across the entire graft surface. Endothelial cells usually only populate a few centimeters in from each anastomosis.
So what covers the rest of it?
The rest of the luminal surface is typically covered by an organized layer of fibrin, platelets, leukocytes, basically a pseudo-intima, not true endothelium.
Do they get atherosclerosis?
Yes, there's a high incidence of lipid and cholesterol deposits and even atheromatous changes detected in late explants. The matrix contains mostly type 3 collagen, but also other types, and some elastin fibrils in the anastomotic neo-intima.
How can endothelium form on them?
Theoretically, through transmural ingrowth from capillaries in the surrounding tissue, which depends on graft porosity, or by migration from the anastomoses, Low porosity grafts show very limited coverage. Higher porosity grafts show more. Wrapping grafts with vein showed uniform coverage, suggesting transmural growth is possible. There's also some evidence for fallout endothelialization cells dropping out of the bloodstream as endothelial islands can form even on impervious grafts.
Does aspirin help?
It helps prevent early thrombosis, but doesn't seem to stop the anastomotic intimal hyperplasia.
Why does the hyperplasia happen right at the anastomosis?
It's likely a combination of the surgical injury itself, flow disturbances caused by the geometry of the connection, and crucially, the compliance mismatch.
Compliance mismatch.
The graft material, like PTFE, is much stiffer than the native artery. This abrupt change in flexibility creates abnormal stresses at the suture line, which is thought to be a major trigger for hyperplasia. Even the suture technique matters. Continuous sutures create a stiffer anastomosis than interrupted ones.
Have people tried to fix that mismatch?
Yes, various anastomotic cuffs or patches, often using a piece of vein, like Linton or Miller cuffs, have been designed to create a more gradual transition in compliance and geometry. They've shown variable success in improving patency by reducing intimal hyperplasia.
So integrating these materials remains a challenge. Finally, let's touch on dialysis access. How does intimal hyperplasia affect fistulas and grafts used for dialysis?
Dialysis access, whether it's an AV fistula using native veins or a prosthetic graft, often suffers from intimal hyperplasia, showing features seen in arteries, veins, and prosthetic materials.
Where does it occur?
Needle puncture sites seal with clot, then scar tissue, and you can see narrowings and thrombus there. But the main problem area is usually the venous anastomosis in grafts, or stenosis within the fistula circuit.
Why the venous anastomosis in grafts?
Again, surgical trauma, flow disturbances due to high flow rates, and that compliance mismatch between the stiff graft and the compliant vein are major drivers. This often leads to stenosis within a couple of years.
Is there thickening elsewhere?
Studies have noted two distinct regions. Thickening right at the anastomosis, which is usually worse in PTFE grafts than native vein fistulas, and also some thickening on the floor of the artery where the graft originates.
Does the type of connection matter?
Probably not significantly for intimal hyperplasia itself, as the flow dynamics tend to be similar whether it's end-to-end or end-to-side. High flow rates are definitely a factor, though unbanded grafts with very high flow develop more venous anastomotic intimal hyperplasia. There's even a correlation shown between the Reynolds number, a measure of turbulence, and subsequent hyperplasia.
What does the tissue look like at the venous anastomosis?
It's typically smooth muscle cells embedded in extensive extracellular matrix proteoglycans near the lumen, collagen, and elastin deeper. There's also significant neovascularization, new blood vessel growth, and perivascular macrophages.
Is there active growth?
Yes, intense proliferative activity in both the endothelial and smooth muscle cells within the neo-intima. Areas with high proliferation often stain strongly for tenascin, a protein linked to remodeling and neovascularization, suggesting a connection.
How is this treated?
Treatment usually targets that venous anastomotic stenosis. Surgical revision with a patch often leads to recurrence. Balloon angioplasty is usually first line. It dilates the stenosis. But patency is often short-lived because the underlying proliferation and matrix deposition continue, and the angioplasty itself adds more injury.
What about stents or DCBs?
Bare metal stents placed across the venous anastomosis haven't proven much better than angioplasty alone. Restenosis occurs quickly through the struts. Stent grafts have shown slightly better, but still fairly poor, patency at 6 months compared to angioplasty.
And DCBs and dialysis access?
Results are mixed. Some small trials showed early improvement in patency of the treated lesion in both fistulas and grafts, but often without impacting the overall access survival at 1 year. So, more investigation is definitely needed. DES use has been pretty minimal here.
Any experimental approaches?
Investigational paclitaxel-coated grafts showed reduced anastomotic hyperplasia in pigs, with a dose-dependent benefit. And another approach using a stretchable PTFE cuff at the venous anastomosis, specifically targeting the compliance mismatch, also reduced hyperplasia in a pig model.
It definitely sounds like dialysis access remains a really tough challenge for managing intimal hyperplasia. Wow. Okay, we have covered a massive amount of ground here on intimal hyperplasia. If you had to boil it down, what are the absolute key takeaways for listeners?
I think the main thing is recognizing intimal hyperplasia as this incredibly complex biological response. It's truly a double-edged sword, absolutely essential for normal development, but also a primary driver behind the failure of so many vascular interventions. You really get a sense of the intricate dance between cells, signals, and mechanical forces.
Yeah, that complexity really comes through. Was there anything in all that detail that particularly stood out to you as surprising or, a newer insight?
For me, it's the evolving understanding of the adventitia, moving from seeing it as just passive structural support to recognizing it as a key regulator, orchestrating things from the outside in. That perspective shift is really significant for how we think about vascular healing and disease.
Yeah, that's a great point. So for someone listening, maybe they or someone they know has vascular issues, or maybe they're just interested in medical science. Why is understanding this intimal hyperplasia process relevant to them?
Well, understanding the triggers, the type of injury, underlying conditions like diabetes or high cholesterol gives you a real appreciation for the challenges doctors face in vascular medicine. And seeing how technologies like DCBs and DES have developed, it shows the ongoing effort to try and manage this fundamental biological response more effectively to improve patient outcomes. It's about understanding the why behind the treatments and their limitations.
Absolutely. And if listeners wanted to chew on this a bit more, what are some open questions or areas to think about?
Oh, definitely. One big one is the long-term implications of that potential mortality signal with paclitaxel devices. What's really going on there, and how can risks be mitigated if they're real?
Right.
And thinking about the adventitia again, could a deeper dive into its signaling pathways unlock totally novel therapeutic targets? Could we manipulate the outside-in signals to prevent harmful hyperplasia?
Those are really good questions for future research. And maybe one final, more provocative thought to leave everyone with.
Go for it.
Given that intimal hyperplasia is at its core, the body's attempt to heal is completely stopping it even the right goal. Or should the focus maybe shift towards modulating it, guiding the healing response towards a more beneficial outcome that maintains vessel patency without causing problematic narrowing?
That's a fantastic question. Modulate versus eliminate. It really gets to the heart of the challenge in intervening in complex biological processes. It's certainly a fascinating and critically important area.
It absolutely is. Well, thank you so much for walking us through all of that, and thank you for joining us on this deep dive.